Good morning and welcome to the Pharmacology Made Insanely Easy. I want to say a very special thank you to NSNA for the invitation and very creative planning to pull all of us together. Of course, we'd all rather be together at a conference, and we're looking forward to when this COVID season and opportunity has decreased that we're able to be together. But for now, I'm looking forward to spending this hour with you on making pharmacology insanely easy. And remember, making pharmacology easy is a go-to link for success. My name is Loretta Manning, and we're going to be having a great time today in terms of looking at how do you simplify a very complex subject such as pharmacology. Now, one of my questions for all of you is, do you ever feel overwhelmed with pharmacology and feel like you have all that information? How do you decide what to do for each of those side effects? And we're going to look at that today. The most important thing in pharmacology is not so much to obtain more and more facts, but to transform how we do think about them. What concerns me about pharmacology or nursing in general is not the way things are, but our perception of what they are. Believe yourself, and remember, whether you think you can or you can't, you're absolutely right. So you must have confidence and have belief in yourself. And that's what we're going to do today. We're all about simplicity and simplifying volumes of information to help you get to the complexity of decision making. And many students feel this way about pharmacology, that when a child is 0 to 4, we put them on a little amoxicillin for those ear problems. They get a little hyperactive like they're supposed to. We put them on a little Ritalin. And then we become adolescents. And between 12 and 18, we take those write our papers or our care plans or study for those exams. So we overdose on no dose. Today it would be caffeine from Starbucks or from Dunkin' Donuts or Red Bull, which is not good for us. But the bottom line is we have that caffeine, and then we come to nursing school, and then we take Prozac, and then we become RNs, and then we have all that stomach issues, and we're on Zantac, and then we're 60, and it's downhill from there. I'm just kidding you. It's not really that way. But that's how we feel many times when it comes to pharmacology. Well, this hour, I do not want pharmacology to be trivializing, tedious, or terrorizing. I want you to recognize that learning is truly directly proportional to how much fun you have. So just think about it. When we have fun, we tend to remember information more than when we don't. So remember, it's not what you know, but it's what you remember that counts as you're looking at pharmacology. So what I've done is I have developed a way to help you cram for this subject. And I'll tell you my story as we go through here, but I didn't just set out to do this. This is something that you guys really encouraged me to do when I was in education. And I took strategies to help you create retention, ways to remember information that does accelerate the process and help you do more with less. My nursing students would come to do their medications, and they would just be paralyzed with information. They just couldn't remember. Have any of you ever happened that way to you, where your faculty asks you a question, you're like, I know it, but I can't remember? Well, I started doodling, and I would just take paper. I take little paper towels, and I start writing mnemonics or little pictures to help them remember information. And they come to the medication cart the next day, and let me tell you, they were just rolling it out. And then I got called in by the dean one day, and I thought, oh my gosh, I've done something wrong, because you just don't get called in the dean when you're a novice educator. And what happened was the National Council was changing their test plan, and they were going from a medical model to a nursing model. And when I said to the dean, am I in trouble? She said, no, quite the contrary. All of your students are doing well on the test, and we want to know what you're doing. And so what I'm going to share with you is what we were doing. And what I did not realize at the time is I was helping students remember by using cognitive learning strategies. So whether you're a visual learner, whether you're an auditory learner, or whether you're a kinesthetic learner, I believe you're going to hope you find that these strategies to be helpful. Now, before we start cramming for today, how many of you would be happy if you could just remember 10 new things about pharmacology in this hour? And you can ask yourself, I wish you were right here with me, but just remember that you can do this. So as we go through here, if I were to take a look at what we're going to do, we're going to take a look at mnemonics, songs, images. We're going to be chunking information that will help you move information into the long-term memory. Because in short-term memory, that's when we get stressed. In fact, you're going to have the opportunity to meet Jennifer and Erica in just a little while. And when in our office, when we have so many things going on, Jennifer will say to us, do we need to know that for tomorrow? Because if not, let's put it on the side, because we have so much information that we want to make sure we don't forget anything. Keep in mind, everything we do today is going to be based on standards. It's not going to be fluff and puff. It's going to be based upon what you must know to be successful on your national examination. As Albert Einstein says, he says it's got to be right, correct? If you can't explain it simply, then you do not understand it well enough. So what I would like to do is to demonstrate that. If I were to give you guys a pop quiz right now about your anticholinergic, you can't pee, can't see, can't spit, and you know the rest. Can't poop, in other words. In other words, why did I start off with this? Well, first of all, pre-op drugs have anticholinergic properties. Anti-Parkinson drugs have anticholinergic properties. Keep in mind, if I've got Parkinson's disease, I have a little tremor. Anti works against the neurotransmitters, which is a cholinergic. That's not a bad thing. So always understand what the drug is doing. So there's a lot of drugs that have anticholinergic properties that you will see again, I guarantee you. One category, those antidepressant medications, especially those tricyclic antidepressants, especially those MAO inhibitors, those have anticholinergic properties. So what does this mean to me as a nursing student or a nurse? Well, here's what it means. First of all, what is that condition that people have that they lose their peripheral vision and they have to take eye drops for the rest of their life? Creates tunnel vision. That's called glaucoma. Would I want anyone with glaucoma taking these drugs? Absolutely not. Men who develop benign prostate hypertrophy, or if individuals have complications of renal disease, do I want to give them something they can't pee? Absolutely not. And then you think about can't spit. What a great delegation question. To be able to delegate to a UAP or even to Loretta, Maine that comes to your floor to work, clients taking anticholinergic properties to make sure I incorporate good oral hygiene so it doesn't get so dry. And then if I can't go to the bathroom, what about elimination, such as fiber, a basic care kind of question. So always think about, what do these mean to me when I'm looking at this as a nurse? So let's link it so you can think it. Before you do, would you please repeat after me? Can't pee, can't see, can't spit, and you know the rest. So let's do it. Which of these clients should the nurse question the provider of care regarding the appropriateness for an order to administer an anticholinergic medication? Remember, can't pee, can't see, can't spit, you know the rest. So let's compare and contrast. 1, a client going to surgery for GI surgery. 2, a client who's presenting with Parkinson's symptoms from antipsychotic drug. 3, a client who has glaucoma. Or 4, a client who's going to surgery for an exploratory lab. Well, while you're observing this at home, I hope you do a compare and contrast, which you always do, because I believe all of you would agree with me. Nursing exams are different than other exams we've taken in other classes. A lot of times we're just spitting out knowledge, but here we have to make a decision. They're going to look good, aren't they? So let's compare and contrast them. 1 and 4, I think it looks similar. So if I did not know this information, I'm going to get rid of those. And then I'm between 2 and 3. Now, number 2 is a client with Parkinson's symptoms, and we know if I did not say that, you would still know it, because you know anti works against what? The cholinergic receptors. So therefore, the answer is number 3. Now, today, in this hour, I do not want us memorizing. I want us to be able to analyze and synthesize, because you know the information so well. So there you have it. Can't pee, can't see, can't spit, and you know the rest. And the answer here is number 3, a client who has glaucoma. Now let's look at those select of apply. I think if we were in the same room, I'd get a lot of booing on this one, right? Students do not like these questions, but here's the question. Which plan should be included for a client taking an anticholinergic medication? There are nothing more than true and false. All you have to do is say yes, no, yes, no. And it's the same thinking, and it's the same strategy. And you know what anticholinergic meds do. So let's do it. What should be included for this patient? Do I want to encourage a diet high in fiber? You betcha. Constipation, fluid and fiber and exercise, real important. Remember, pharmacology is going to be married to your information on basic care. So yes. Are we going to encourage a clear liquid diet? I don't think so. If I have a clear liquid diet, I can't take that diet high in fiber. So we need that fiber. We need fluids, but not just a clear liquid diet. So 2, I would say no. Provide oral hygiene several times a shift or as needed. Can't spit. I think it's a great idea. Absolutely, number 3. If it just said once a shift, that would be wrong because they need oral hygiene more frequently when they're taking these drugs. Their mouth gets really dry. 4, assist a client in drinking fluids hourly. You betcha. There's no indication of cardiac client, no indication of neural client, no indication of any kind of complication that would contraindicate giving them extra fluid. So I'm going to say yes. And lastly, advise the client to expect to experience some diarrhea. I don't think so. They're going to have constipation. So there you have it. The answer is to encourage a diet high in fiber, number 1, provide oral hygiene several times a shift or as needed, number 2, and number 4, assist client in drinking fluids hourly. See, you can do this when you know your information with a simplex approach, simplifying large volumes of information. So let's move on. What I'd like for you to do while you're at home, take out a piece of paper if you would. I would like for you, do you see, everyone see this? Everybody okay? I'd like for you to write down on a piece of paper what you just saw. It would take a couple of seconds for you to do that. Write down what you just saw up there. Okay, now, how many of you got those correct? Some of you are looking at me, why did you do this? This is not about pharmacology. However, isn't this how we feel many times about our faculty put all these isolated information up here and then shut it off? But you know what? I believe if I would have given you a tic-tac-toe board, I bet you almost every one of you guys would have gotten that correct because you have an image or you have something to associate it with. And what happens with those pharmacology books, the reason they're so big and the reason those med-surg books have 4,000 pages and are this big and the paper and the writing is so little is because they put everything but the kitchen sink in those. But you know what we're going to do is we're going to show you how to study and how to be successful. Remember, less is best and more is a bore as long as it's the right information. So I promise you I won't do this to you anymore today because I did not give you any idea what I was going to do and I didn't give you an image to work with it. So what does this mean about pharmacology? Let's move forward. Let's do your first drug. During the history, a client reports a previous allergic reaction to penicillin. The provider of care orders Cefaclor. What is the highest priority of care? Now, I've included both the trade and generic because I wasn't certain who my audience would be. But those of you getting ready to take your NCLEX exam very shortly, you will only have Cefaclor up here. Don't worry about it because that's how we organize everything in our books and our presentations is around the generic way. Because remember, we want it to make it easy, actually insanely easy, so you can remember the information. So in looking at this, what is the highest priority of care? Well, would it be a millistart an IV? How about identify the risk bracelet for correct client identification? The number 2 NCLEX standard out of 140. Pretty important. How about verify accuracy of order? Or how about monitor the bun and creatinine prior to administering the medication? We've got several up here that's looking pretty good. My goal today is not to trick you at all. It's to help you be successful. So how do we do this? Now, if you know this, we're proud of you. We'll come back to this when you will know it for sure. But let's look at our memory strategy or our test-taking strategy. And this would be in a book called Pharmacology Made Insanely Easy. And this simplifies about 25 pages out of a pharm book into one word. Now, if you're not a visual learner, it's okay. But we do know that 98% of adults are visual learners. Now, keep in mind, if you are a kinesthetic learner or if you're an auditory learner, memorize it. It's not about memorization today. This is about how do I organize it. So GIANT, a mnemonic, is not memorization, but it's certainly a lot easier to look up what the standards are in one word than to look at 20 pages of information from a med-surg or a pharmacology book. Wouldn't you agree? So in doing this, 80% of these drugs, well, first of all, let me just say this. They all have a Ceph in them. Ceph. There's probably 25 to 30 of them. So if you said you wanted to remember 10 things from today, you've already got it, so you can turn Zoom off. I'm just kidding you, don't do that. We're just getting started. But remember, they all have a CEF or a CEPH, and that's all you really need to remember. And they have giant undesirable effects. They also go after giant organisms, but I'm not so concerned about those organisms because you and I are not going to actually be prescribing as nurses. We're going to be handling those undesirable effects. 80% of these drugs cause GI distress. Now, the thing to remember is it's okay to have some nausea, vomiting, and anorexia, but no diarrhea, because if they have diarrhea, they could have C. diff, and we don't want that to happen. So remember, nausea, vomiting, yes, that's expected. Diarrhea, we need to report it because of C. diff. Now, you and I, all across the country that's watching this, we're not going to have increased glucose values unless I'm 90 years old, or unless I have diabetes or have pancreatitis, or I'm taking one of those drugs that create an increase in sugar called corticosteroids. If I'm taking those, then that would drive it up. But remember, you can what if me all that you want to when we have our question and answer period. If we were in the same room, we could do it right now. But remember, if you're what if in a question, you're saying, are they taking corticosteroids? You're going down the wrong path there, because they're going to give you exactly what you need. So if I don't say diabetes, if I don't say 90 years old, if penicillin as well as your cephalosporins have the same chemical structure. Now, what that means is if they have the same chemical structure, there is a risk for them to develop complications with allergies. Whenever you can give them interchangeably, they can have interchangeable hypersensitivity. So when you see that they can give them interchangeably, you always ask them, have you had any previous allergic reaction to either one of them? Because they can get into those problems. My mother had hypersensitivity to both of those to take cephalosporins. Many of my patients are that way. Some people are fine, but you always ask the question, have you, or check the appropriateness of the order. Now, these, we don't want to give them anything with alcohol in them. Do I think they're going to say alcohol? I don't think so. They're going to talk about cough syrup, over-the-counter cold medicine, mouthwash, hairspray, shaving cream, anything with alcohol in them, they're going to question that. But I don't think they're just going to come out and say alcohol. That's too obvious. Nephrotoxicity. I don't think they're going to say nephrotoxicity either, because they don't come up with a sign that goes, hello, I'm nephrotoxic. They have no idea what it means. So the bun and creatinine, if that's an appropriate answer. But remember, the engine of the question will drive what you're going to do. And then we've got a concern with thrombocytopenia. So we're going to be careful with bleeding because of the platelets. So there you go. 5 major concerns with Ceph the Giant. They all have a cephalosporins, can have a CEF or CEPH. Concern with GI, that's okay. Diarrhea, not okay. Increase in glucose values only if they have problems with hyperglycemia already from diabetes, have pancreatitis, or they're taking corticosteroids that can drive the blood sugar up, or if I'm old, like 90 years old. Anaphylaxis can occur if they have hypersensitivity to penicillin, so be very careful and question that. Be careful with anything with alcohol, like shaving cream, over-the-counter cold medicine, mouthwash. Watch for nephrotoxicity. How do you do it? Monitor the bun and creatinine, and then be careful with bleeding from the platelets. So let's go back to your question. During the history of client reports of previous allergic reaction to penicillin, the provider of care now has ordered Cephalcor. What is the highest priority of care? The highest priority is going to be number C as in Charlie, verify the accuracy of the order. Why? Because you have a previous allergic reaction. Now, the reason I put the trade name out there is because if you're just starting a nursing school, you may need to learn both of those for your schools, but recognize at the end, the National Council will only have typically the generic name. And I want you to study the generic name. That's how I do all of my medications and my books, to help make it easy. Remember, my job today is to help you work smarter, not harder. Very good. The other ones are important, but remember the key words is they had allergic reactions. So it's all about safety, safety, safety. So it's verify the accuracy of the order. Very good. Okay, well, let's go to another select I'll apply so you realize you can't do this. What should be included in a teaching plan for our client taking Cephalcor? Select all that apply. So report signs of hypoglycemia. Is it hypoglycemia or is it hyperglycemia? Encourage you to take cough syrup with Cephalcor. What's in cough syrup? Over-the-counter medicines. What's in hairspray, shaving cream? Review importance of monitoring abundant creatinine levels. That's important. Report oozing of blood around the IV site. What goes on with the patient? Thrombocytopenia. And advise the client to expect some anorexia. They can. So what are your answers? The answers are going to be number 3, 4, and 5. Excellent. Now, if I said, advise client to expect some diarrhea, that would be wrong because we'd be worried about C. diff. So you've got the concern with the renal, you've got the concern with thrombocytopenia for number 4, and you know that it's okay to expect some anorexia. Just no diarrhea. Very good. Good job, guys. So what we've done is we've gone through and looked at your anti-cholesterol properties. Can't pee, can't see, can't spit, you know the rest. We've looked at cephalogyne, all those magnitude of numbers in terms of with cephalosporins. They all have a CEF or a CEPH is all you need to know. And they go after giant organisms. Remember GI, increase in glucose values, anaphylaxis to penicillin, concern with alcohol, watch for nephrotoxicity and thrombocytopenia. Well, failure will never overtake my determination to succeed is strong enough. And it is. Your determination or you wouldn't be here. So we admire you and you're little eagles. So let's take a look at neuronal theory. Remember, when we study, when we just memorize, we're just getting little nodes in our brain. Well, that's not where it is. Link it so you can think it. So we're going to be making connections today to help you remember information, which is where memory occurs. Remember, memory traces are small in number. There are very few linkages. So as nursing students, if I ask you guys, do you ever feel overwhelmed with pharmacology? I bet all of you would be going, I do, because there's so much information. And in fact, in my workshops, in my books, I always show you how to learn so that you don't have to get so overwhelmed. I just finished a workshop with a group of faculty not too long ago, and one of the faculty members said, Loretta, would you go through the top 200 drugs? I said, I will, but you know, that seems pretty overwhelming to me as a nursing student. I think the question to ask is, how do we organize them? And that's what we're going to do today to make it easy for you. This time I'll be nice to you. For example, let's now look at this drug up here, galantamine. Once you look at this, remember, what does galantamine do? And I would like for you to take just a few seconds and only look at the image, please. Now, if I were to say, what's in that image? How many times a day do we take it? Hopefully, remember 2. And how many weeks before we change it? Hopefully 4. And then do we take it with food? You betcha. And if it's extended release, we take it in the morning. So typically we take it that twice a day. Now, when you look at this, what you have done in just a few minutes is looked at the NCLEX standards, because all the images, the songs, the mnemonics, I hope you brought your singing voice today, all of that is going to help us remember information. So remember, 4 weeks, 2 times a day, remember cognitive enhancer, it's going to help them feel better. They're not going to be able to fix it, but a significant improvement in memory is better than no memory at all. And remember, the mnemonic will always help you as well. It will tie in the picture or the song or what's on the left side of the page. So remember, minimum 4 weeks before increasing it, extended release with food. Think about Alzheimer's, why we give it. Oral dose, preferably in the morning and evening with meals, unless it's extended release, it would just be in the morning with meals. Desired outcome is a significant improvement, doesn't fix it, but does improve. And yes, monitor for that low heart rate. Look at you, in just a few seconds, you've organized what you need to know. Now let's link it so we can think it. Which of these statements indicate the client has an appropriate understanding of how to take galantamine after being discharged from the hospital? Remember our picture, remember 4, remember 2, remember heart rate, remember food, and that's your clinical decision-making / test-taking strategies. You can do this, believe in yourself. 1, I will take this medication on empty stomach. 2, I will take this medication 1 time a day. 3, this medication should be reordered after 3 weeks. Or 4, I will notify my healthcare provider if the heart rate goes below 60 beats per minute. What is the answer? The answer is, yes, I want 4. I will notify my healthcare provider if my heart rate goes below 60 beats per minute, because go back to the image and what you need to know is in that image. Less is best and more is a bore, as long as it's in the right information. Number 4. Next question is, Which information should be included in the teaching plan for a client with a new order for galantamine after being discharged from a hospital? Select all that apply. You can do this, same image, just remember it's only true and false. So number one, are we going to instruct them to take it on an empty stomach? No, no. Are we going to educate to take it one time a day? No. Are we going to advise them to come back to the clinic for a new prescription after 2 weeks? No. But are we going to teach them to report a pulse if it goes less than 60 beats per minute? You betcha. Are we going to inform the family that the client should experience a significant improvement in memory? Yes, it's going to be improvement. Now, it may not be significant for you and me, but let me tell you, my mother-in-law has a dementia, and she is a precious lady, and we know when she can take partner activities of daily living because there's a significant improvement with her medications. Doesn't fix it, but we're able to move forward. So the answers are 4 and 5. Look at you. Perfect. So now you have another way to remember galantamine. Remember, connections are required for learning. Have you guys ever learned something for school and then dumped it for one task and dump it for the next task? Better yet, we all have done that because we haven't connected the information. We got to link it so we can think it. The more connections form, the greater that can be formed. Remember, neurons that fire together are wired together. That's what we want. And initial learning is only temporary. You're not bad at all that you dump it out. It's we never got into the long-term memory. Repetition is critical for learning. You need to hear what the new research shows 8 times to be able to get it into the long-term memory. So if I'm repeating myself, it's not because I'm having a senior moment, I promise you. I am trying to, in this hour, move information into your long-term memory. And remember, brain recontouring can be positive or negative. And I want you to believe in yourself. Learning should be fun, always. Remember, if indeed, have you ever studied for a test and it was the wrong information? Oh my goodness, that is overwhelming. You just are mortified. You just want to, at least I did, I just want to stop nursing school. But remember, it's because you don't know what's relevant versus irrelevant. So let us help you because everything we do is based on NCLEX standards. And what I want to do is to demonstrate that to you. I want to demonstrate that to you with morphine. Last year, there were $3.5 billion spent in medication errors. It was you guys that got me to this workshop. I didn't set out to do it. It was my nursing students that said, oh my gosh, can you do more and more? And what happened is after one of my last NCLEX reviews many years ago, the students went to the director and said, could she come back and look at pharmacology? Because the reality is pharmacology is so overwhelming. At that point, I didn't have a program. But since then, we have developed it. It's been the most popular program. Because as you see here is, you can bet that opioids are going to be on your test. And you can bet you're going to see it. Why? $3.5 billion. And excuse me, the latest research I saw went up $1 billion, $4.5 billion. And that was just 2 years ago, was 3.5. We got more information now than we've ever had at our fingertips and more medication errors than we've ever had. So how do you remember morphine or opioids? Well, you know, it's all the same. We study in families of drugs. So remember, droopy deuteronomy, he is drooping. So he's drowsy, he's dizzy, he has depressed respirations. He shouldn't have all these. That's, of course, what we're going to monitor for because you are the nurse taking care of the patient to prevent a train wreck from occurring. And he can develop decreased GI peristalsis and a decreased urine output. Not good. None of those are good. Now, remember, we're not going to wait for them just to bottom out or a decreased blood pressure. We're going to watch the trending going down. Now, the textbooks are going to tell you, watch for urine output under 30 or watch for that respirations under 10 to 12. But you are going to be a nurse, a brand new graduate taking this in class. So you want to remember the importance of looking at the trend. So that's what we're going to do in clinical practice. So monitor a trend of their drowsiness, it's early, dizziness, depressed respirations, and they're in order. First, they get drowsiness, then the respirations go down, and then they can get into peristalsis, in other words, constipation, decreased urine output, and decreased blood pressure. So that covers all of your opioids. And if he gets too many, he's going to be percolator, naloxone. We have to many times give that on the street because of so many opioid overdoses, and it's getting worse with this COVID. It's so sad. But we have to remember to have that behavior that's contagious, that optimistic, and have a vision and be positive. But the bottom line is, unfortunately, not everyone is that way. So in doing that, we're going to think about giving naloxone to get that pulse up, perspirations, excuse the expression, all the P's, puke, pain, and pressure. See how easy that is? Remember, droopy deuteronomy, if it gets too much, We need to perk him away. So before my team comes, let's take a look at a question here. Which of these clinical assessment findings are priority to report to the provider of care for a client who's receiving morphine via the PCA pump? So remember droopy deuteronomy, heart rate has changed from 90 beats per minute in 1 hour to 70, and let me see here, 70, I've got a little picture of my way, 78 beats per minute. We're gonna look at pupils are 5 millimeters and equal, clients becoming more lethargic, or the respiratory rate has changed in 1 hour from 28 per minute to 14. Well, number 3 is early. So the answer is number 4 because they're trending down. They're getting close to that 10 to 12. So there you have it. Droopy deuteronomy is to help you with that process. So remember, it's decreasing. So number 4 is your answer. Well, I hope you brought your singing voices. I've got some very special people here because we really were not going to do pharmacokaraoke, but my dear family and my dearest friend said, no, we need to do this. So we're going to encourage you to join us at home. We realize you're not actually in the same room with us, but hopefully you can see. I'd like to introduce on my left, my right, my dear husband. This is Randy. He can sing a lot better than I can. I just write these things. To my other side, to my left, is my precious daughter, Erica Manning. She runs the show here with all this virtual information. We couldn't have kept this whole few months going without her. And then we have behind me our dearest Jennifer Robinson, who keeps everything going. When you call, Jennifer is the one that will take care of you, I promise you. And she keeps us all going in the right direction. So remember, words and music are, of course, the most powerful drugs used by mankind. Now, if you're not a kinesthetic learner and don't learn this way, it's fine because we're going to be pulling it together so you can link it, so you can think it. But remember, as you wander through life, whatever be your goal, keep your eye upon the donut and not upon the hole. We're going to sing some songs. As soon as we sing a song, we're going to link it to what you need to know for your clinical practice. So the first thing we want to do is just introduce pharmacokaraoke. And we want you to do this at home. We'd like for you to join us when it becomes red, when it says, and you just say pharmacology made easy, pharmacology made easy. We'd have some contest if we were in the room, but since we're doing this Zoom, they're going to help us out. But here we go. 1, 2, ready, go. Pharmacokaraoke is the way to go. You will learn all the meds that you need to know. It's easy as learning the ABCs when you learn your facts with pharmacokaraoke.
Pharmacology made easy, pharmacology made easy.
You may ask about all the drug interactions. Just listen to our songs for your direction. Reviewing meds can be fun and exciting and can be very enlightening.
Pharmacology made easy, pharmacology made easy.
Just check out the icons and images in our book. You will soon be singing. Just look how smart you will look. Pharmacology made easy, pharmacology made easy. Good job, team. Awesome. Hope you did it at home as well. We'd like to introduce you to our first group of medications. You will see these again. These are your aminoglycosides. They all have a mice in them. And I'm only asking you to remember 3 things. 1 can't hear and 1 can't go. Remember, 2 ears, 2 kidneys. When you have ototoxicity, typically you can develop problems with nephrotoxicity. Remember from your classes during embryology, where your auditory system is developed, the renal system is developed as well. And then, of course, with renal, you have to monitor that bun and creatinine, and a lot of drugs create nephrotoxicity, so we have to monitor that. And then, of course, they can get into paresthesia where they can't feel. Now, before we do this, what we would like to do is to take a look at, if you can't remember your cranial nerves, I mean, how many of you know your cranial nerves like the back of your hand? Anybody? If you can't, you're going to know these in just a few minutes. So I'm going to, if you're just starting off, really the numbers are just fine. However, if you've got, as you're getting ready to graduate, you do need to know the actual names of them. But number 1, here we go. Number 1, God gave me 1 nose, and that would be olfactory. And 2 eyes would be optic vision. That's where I would go ahead and ask Jennifer to see my numbers, or I do a Snellen chart and ask her to see what she could see. 3, 4, 6 makes your eyes do tricks. 3, 4, 6 is your oculomotor, your trochlear, and your abducens. And that helps you in terms of with the eye movement. Oculomotor is basically going to be looking at the constriction of the pupils, but bottom line is we look at both, all of that together. So 3, 4, 6 makes your eyes do tricks. So let's do it, everybody. Number 1 is the nose, 2 are the eyes, 3, 4, 6 makes your eyes do tricks. Now 5 is very simple because 5 rhymes with try. So 5 is your trigeminal. Now in our books, trigeminal, we call them trigeminal neuralgia, and we use the word pain because it's very, very painful. It's actually a suicidal pain. And we also call them lukewarm because it hurts so badly, but they have both sensory and motor complications. So number 5 is try. Now 7, go ahead, Jennifer, let's go across our face. We want you to number 5, think about number 5 is your Bell's, number 7, 5 is try. Let's move on, Loretta here. So number 7 is your facial. And so you want to take a 7 across your face, and that would be your Bell's palsy. So 7 is the face. And if there's a problem with the 7th cranial nerve, it would be more about image. Whereas 5 try is about pain. Number 7 is about image. Now number 8 goes in your ear, so you can put an 8 in your ear. You can take an 8 back and forth. Number 8 is about hearing. So that's the big thing today. I want you to leave here with number 8 in your mind. It's never okay to have tinnitus. They can have tinnitus here with aminoglycosides, not good. You need to report it. We'll talk about vancomycin. That's not good. Aspirin's not good. So we want to be careful with number 8. 9 and 10 go under your chin. 9 and 10 are check a gag reflex, and they have a G in them, glossopharyngeal and vagus. And then number 11, put your on your shoulders. Number 11 are going to be your spinal accessory. And 12, I couldn't think of anything. So 12 is the end. Just think about the tongue has the last word. So in doing that, in review, and insanely easy approach to your cranial nerves is number 1 is your nose. 2 are your eyes. 3, 4, 6 makes your eyes do tricks. 5 rhymes with try. 7 is your face. 8 are your ears. 9 and 10 under your chin. 11, your shoulders, spinal accessory, and 12, hypoglossal. So in review, just think about if there were just a few to know, remember 1, nose, 2, eyes, 11, shoulders, 8, your ears. So I want you just to always be able to remember that. And if you only remember one thing, remember your ears. Well, my team is going to join us now. And we're going to go ahead and we're going to mice, but it's going to be our 3 amino mice. Everything you know is in this song. All we care that you know about is that you can't feel, can't hear, can't pee is what we want you to know. So on the count of 3, we want you to join us. 1, 2, 3, go. 1 can't feel, 1 can't hear, 1 can't pee. They're toxic mice, all 3. Vestibular function and audiogram should always be studied in patient care plans. Grab buns and crayon quick as you can. Yes, 3 amino mice. Good job, guys. Good job at home as well. Bottom line is 1 can't feel, 1 can't hear, 1 can't pee. That's toxic mice, all 3. Well, let's link it so you can think it. Which of these clinical data findings would be the highest priority to report to the provider of care for a client who's been taking gentamicin? Remember, 1 can't feel, 1 can't hear, 1 can't pee. Bun of 15, nausea, temperature of 98.9 degrees Fahrenheit, or tinnitus. You got it. Absolutely. Tinnitus, that number 4. Excellent. Now, here's even a better question. Which statement made by the unlicensed assistant personnel indicates the nurse should intervene with a client who's been taking streptomycin? The client's temperature is 99.1 degrees Fahrenheit. The client does not seem to hear me. The client is requesting to walk, or the client is drinking a lot of water. What's the answer? Absolutely. The answer is going to be number 2, and that's a better question because they don't know what tinnitus is. So number 2, outstanding. Which should be the priority plan for a client who's taken streptomycin? The priority plan for streptomycin, you know, 1 can't feel, 1 can't hear, 1 can't pee. Monitor the vital signs prior to administering the medication. Monitor the AST and the ALT. Monitor the bun and creatinine, or monitor the serum glucose. What do you guys think? Absolutely. My team is saying number 3, 1 can't pee. You got it. Wonderful. Hey, you're doing well. And I bet you're doing that at home as well. Okay, my team's going to come back. This is one of our favorites. You guys will all know this. Vancomycin will be on your test. There's an increase of vancomycin because of the high rise with HIV and all the opportunistic organisms. What I want to point out, we always like you to know what you're listen to for the psalm. Caution with renal failure, hearing loss, and allergies, those are problems. Notice, once again, same thing with your amino guys, hearing loss and renal failure. Now, the thing to remember is this drug should be given slowly, because if it's given faster than an hour, they're going to get redneck. So don't call me and say, we're getting redneck if it's going over an hour. The protocol, or in other words, the standard practice, is to give it over at least 1 hour. So if they say 20 minutes, just slow it down, because that's not within the standard of care. Now, the last 2 lines are our evidence-based practice with all of your antibiotics. Take a temp and blood cultures, especially that CBC. With all of them, the temperature should come back to within the defined limit. We should have negative blood cultures, and that white blood cell count, 5 to 10,000 is our normal range, should start coming down. So on the count of 3, Rudolph the Red-Necked versus Rudolph the Red-Nosed Reindeer. 1, 2, 3, go. Rudolph the Red-Necked Reindeer had an adverse side effect from the drug vancomycin. Must keep all the labs in check. Yes, you better. Caution with renal failure, hearing loss and allergies. Take a temp and blood cultures, especially that CBC. Awesome. Okay, now, what action should be a priority for a client who's receiving vancomycin over 30 minutes and begins presenting with a flushed neck and face? 30 minutes. Assess that client's temperature immediately. Administer the antihistamine that was ordered. Immediately discontinue the med, or slow the rate of the drug infusion. Slow the rate. It gave you 30 minutes. If it's in the engine of the question, pay attention. It's going to be number 4. I want all of you to recognize I do not believe in cheap strategies. Those mean things like you could always answer it this way, or always assess, or always position a client upright. You're beyond that. This test is all about high-level clinical decision-making, where we must master med-surg, we must master maternal newborn, we must master pharmacology. And the reality today is, if you can master this, you know you can do it. So the answer, therefore, without a doubt, is slow that rate, as you know from the song. Okay, well, we're going to move on while my team is coming back. Bottom line is, we've looked at anticholinergics before we started the song. We looked at droopy deuterotomy. We looked at galantamine. We looked at one can't feel, one can't hear, one can't pee. And now we've looked at Rudolph the Red-Necked Reindeer. Now we're going to go to a major anti-protozoa drug called amphotericin. That's called amphotericin. Now the picture, we keep them simple because you want you to remember it. If it gets too much information, we get overloaded. The brain just shuts down, actually, shuts down. So something's going to go on with the heart. We don't want it to infiltrate. And there's a little X on the kidney, so something must be an issue with that. So we're going to share with you what you need to know here. This is sung to the tune of the Addams Family. So at home, feel free to snap with us. Feel free to join with us. All I want you to know, I'm going to walk you through it right now. The first 2 verses, I just want you to know, but it's hard on the kidneys. And then we come over here. You can snap with us as we do this. Strychnine, no. Kidney functions must know. And now we're going to add the liver. ALT below 60, AST below 40, keep IVF flow. And then we're going to add, so watch for low K levels, because you guys know before this that low potassium can lead to dish toxicity. So catch problems before they swell, amphotericin B. This is 25 pages at a farm. You've got it. You can do this without a doubt. So group, on the count of 3, amphotericin. 1, 2, ready, go. Amphotericin B, foe of fungus you see, but it's hard on the kidneys. Amphotericin B will kill histoplasmosis, coccidiomycosis. This drug's really ferocious. Amphotericin B, da-da-da-da, da-da-da, 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 da-da-da. Here we go, strychnine, no. Kidney functions must know. ALT below 60, AST below 40, keep IVF flow. So watch for low K levels and ditch toxic signs as well. Catch problems before they swell. Amphotericin B. Great job. Now let's link this so we can think this. What lab values would be most important to evaluate for a client who's taken amphotericin B? This would be a great select all apply. Let's think about it. What would they need to know? Liver, renal, white blood cells, cultures, DIG. I always want you to look for numerous answers because I believe in you and know you can do it. You can believe in yourself as well. So let's do it. Yes, no, yes, no. Would it be AST, ALT? Would it be serum amylase? Would it be serum glucose? Or would it be serum lipase? You got it. The answer is number one. But once again, while we've got liver up here, great, select all, apply. And you got this song. That's all you need. Perfect. Wonderful. Let's do another decision-making question. Which clinical assessment findings should be priority to report to the provider of care? For a client who's been taking amphotericin B, anorexia, muscle cramps, spike T waves, or skin hot and dry. What do you guys think? Well, I will tell you what students say all around the country. They go with spike T waves because test-taking strategies that do not represent clinical decision-making strategies, which are about the standards for NCLEX, will always go with spike T waves, always go with airway, always set the patient up right. You're beyond that. That's not true. You have to remember, if there's one gift that we can give you today, that one gift is pathophysiology. Pathophysiology is always your best friend. So I want you to remember pathophysiology, pharmacology, prioritization, physical assessment, and protect the client from trends and changes so that you can intervene before the train wreck comes. So the reality is, what do we know? The answer is not spike T waves. So watch for low K levels and toxic signs as well. Low potassium is our answer. The answer is number 2. Now, if it would have said flattened T waves, we would get rid of muscle cramps because it's never equal answers. It's just about decision making. So, but spike T waves are not. That's about hyperkalemia. They get into low potassium. Then some students will say, but they can die from hyperkalemia. They can, but do you get hyperkalemia from Lasix or furosemide? No. Do you get hyperkalemia when you get into complications with K-oxalate where you're losing potassium? No. So the reality is, I want you to recognize that it's going to be all about the muscle cramps, or it might even be looking at a problem with a flattened T wave, all the assessments of low potassium. So the answer is going to be that number 2. Very, very good. Okay, so we've looked at amphotericin as my group comes back for our last song with you. We've looked at all the issues with your amphotericin. You guys know about amphotericin now. You know about low potassium leads to dish toxicity, and you know about the importance of monitoring the AST, the ALT, the abundant creatinine. Now, this drug, it seems like aunt, uncle, mom, dad, cat, dog, hamster, birds, you name it, is on statins for cholesterol. Now, the thing to remember is they all end in statin. Now, remember, as I'm going through these drugs and as we're singing about them, we're talking about families of drugs, but they're going to be testing you on individual. But if there's something unique about the individual drug, they're not going to test on that. There is all about knowing that you're a safe nurse. You don't have to know everything about pharm, but you have to know those standards, which is what we're looking at right now. So the big thing is officer LL statin is stopping the liver mobile because those drugs go to the liver. Now, one thing we don't have, and if you can figure out a way to put in a song, you send it to Jennifer and our team here at ICANN Publishing, and we will print you in the next book. How cool would that be? But we could not figure out how to put rhabdomyolysis in here. But I do want you to know rhabdomyolysis is a problem with muscle cramping and the muscle deterioration that can occur from these drugs. So their calves hurt, all kinds of things can occur with muscle when that muscle starts to deteriorate. So that is a major problem. But in this song, what we want you to know is we're going to be singing a spoonful of Lipitor, but it's sung to a spoonful of sugar from Mary Poppins. But what we do want you to know is in this first part, pushing fluid is our big thing, pushing fluid. Over here, we want you to know, always take this drug with food and at bedtime. Cholesterol is manufactured at night, so we take it at night. And they test this way, so you'll know it because it's in a song. It would be great to increase fiber in diet. It will take several weeks before lipids decrease. That's really your bottom line with clinical judgment, decision making, and then of course rhabdomyolysis as well. So sing it along with us about a spoonful of Lipitor to a spoonful of sugar. 1, 2, ready, go. In every job that must be done, there is an element of fun. You find the fun and snap, the job is a game. And every task you undertake becomes a piece of cake. Pushing fluids, a special diet. It's very clear to see. Everybody, Just a spoonful of Lipitor makes the cholesterol go down. The cholesterol go down. The cholesterol go down. Just a spoonful of Lipitor makes the cholesterol go down in the therapeutic range. Always take this drug with food. And at bedtime, it would be great to increase fiber in diet. It will take several weeks before lipids decrease. So everybody, just a spoonful of Lipitor can make the liver enzymes go up. The liver enzymes go up. The liver enzymes go up. Just a spoonful of Lipitor can make the liver enzymes go up. Out of therapeutic range. One more time. Just a spoonful of Lipitor makes the cholesterol go down. The cholesterol go down. The cholesterol go down. Just a spoonful of Lipitor makes the cholesterol go down in the therapeutic range. Great team. Let's give them a round of applause. Good job. Good job. Okay, thank you guys so very, very much. And applaud yourself at home. So now let's link it so we can think it. Thank you guys. Which observation indicates the LPN understands how to safely administer atorvastatin? Remember the song. Assess vital signs daily. Administer at bedtime with food. Administer on empty stomach. Or advise that the level of cholesterol should decrease within 7 to 10 days. Absolutely. The answer is going to be administer. It's number 2. Take it at bedtime with food. Now, it would be perfect if they said fiber, but they don't always give you what you want. So sometimes you have to do the best you can with what you have. But yes, we're going to take it with food. And the other thing we could have said is we could also say, in terms of looking at this, you know, with food, we also want to report if they have any kind of muscle cramping. Like that would pull in that rhabdomyolysis as well. Very, very good. All righty. What have you just done? You've taken a look at Rudolph the Red-Necked Reindeer had an adverse side effect. It needs to go in over an hour. Of course, they're going to get redneck if it goes in too quickly. Concern with hearing, concern with renal. We looked at one can't feel, one can't hear, one can't pee for aminoglycosides. We took a look at amphotericin B, the concern with low potassium and ditch toxicity. And we also said with amphotericin that we want to think about monitoring in terms of looking at their lab reports very carefully, and the AST and the ALT and the BUN and the creatinine and the potassium and the white blood cell and the cultures. You got it. And then we looked at Lipitor. Now, I want to wrap up with beta-2 adrenergic agonists because we all need oxygen to live. And Albute is to the rescue. I want to show you how the pictures work. Every picture has been designed by an artist. Now, we provide the information about information they need to know, what you need to know from a testing standpoint and clinical decision-making. And that all comes from the Institute for Safe Medicine Practice. But what I want you to look at on the screen as we're all looking at it together, on the left are the desired outcomes for Albute. In other words, albuterol, beta-2 adrenergic agonist. Notice they affect beta. They got 2 balloons and 1 heart because beta-2s are about the lungs and beta-1 is about the heart. So beta-2 are going to help with the beta receptors and help relax the alveoli, the bronchioles, and help increase vital capacity so we can blow up those balloons. If they get in trouble, however, or if one of the undesirable effects might be a little shaky wrist. Now, it affects beta-1, they can also get into heart rate going up, and they can get to an increased blood pressure. But remember, it can also not be expected because if indeed I have little tremors, my heart rate goes up from 78 to 90, that's expected. But what if my heart rate is 78 and it goes up to 128? That's not okay. What if my blood pressure goes from 108 over 68 to 150 over 90? That's not okay. But it might go up a few beats. So you have to use clinical decision-making and clinical judgment. Albute is opening the airways and decreasing airway resistance with just one single inhalation. So this is really your picture to help you remember. Remember, it increases the retention up to 300%. And you will see, and remember, Albute to the rescue. Remember, ABC. Albuterol comes before corticosteroids because you got to open up those alveoli for them to be able to breathe. So let's link it. A client received 2 extra doses of albuterol for relief of bronchoconstriction from COPD. What is the priority of care? He got 2 extra doses of that. So are we going to notify the provider of care? What are we going to tell them? Are we going to document bradycardia? Do they get into bradycardia, or does it stimulate beta 1? Complete appropriate report and document complications of lethargy. Do they get lethargic or do they get hyperactive with the tremors? Or document tachycardia and tremors and notify the provider of care. And the answer is D as in David, you got it. Notify about tachycardia and tremors, because that's what happens. And maybe even a little tremors or a little, we've got tremors on here, but a little hyperactivity, excuse me, we could say, or maybe even an increase in blood pressure. So the answer is D. Be careful, you guys. Don't just go with those strategies and say, always notify them, because got to tell them something. Joint Commission says, you've got to go through that SBAR and tell them what's going on. So now you're going to marry that physiology with your pharmacology. Words, of course, are the most powerful drug used by mankind. And let's face it, we've looked at anticholinergics, can't pee, can't see, can't spit, you know the rest. We've taken a look at galantamine. We took a look at twice a day, 4 weeks before we change it. It does help them with their memory. We've taken a look at the patient who's taken cephalosporin, Septogiant. Remember what giant stands for? GI, no diarrhea though. Increase in glucose values only if they're aged, only if they take a drug like steroids that causes those steroids, by the way, and SONE, S-O-N-E. And we've also got a concern with these patients if indeed they have pancreatitis or diabetes or anything wrong with the pancreas that can drive the sugar up. Remember, if they have allergic reaction to penicillin, we need to report that, because that may not be okay. Even though we can give it interchangeably, we need to check with them first to see if they've had any previous problems with it. No alcohol or anything with alcohol like hairspray, mouthwash, shaving cream. No, monitor that bunocreatinine for nephrotoxicity, so know your bunocreatinine, and know the concern with thrombocytopenia. And then we went through and we looked at morphine, droopy deuterotomy, all the Ds are going down. But remember, look at the trends. Don't wait for the urine output to get under 30. If it's been 80 and now it's 40, it's a concern. If the respirations are 24 and now they're 14, it's a concern, they're trending down. Now, if they were 15 and down to 30, that's a good thing. We got to get them down, and that's expected. But remember, there are safety issues with all these medications. And last year, there were $4.5 billion spent on medication errors. And then we went through and we took a look at your pharmacokaraoke. And yes, we had some fun with that. But in all seriousness, we do know one can't feel, one can't hear, one can't pee as aminoglycosides. We do know about vancomycin, a concern with the redneck. And we know about amphotericin or amphotericol, the concern with renal toxicity, and monitor for low potassium and DIG level, because it can lead to DIG toxicity only if they're taking DIG, of course. And then we went through and we looked at your statins. And then we wrapped up with albuterol. Well, let's face it, you can do this. You can be a pharmacology genius with the right information. Remember, and tools. Pharmacology is always changing. It's our response is what and our thoughts make it. So what we hope that we are able to do in this hour is transform and get rid of fear. So it's a successful experience. Get rid of false expectations of appearing real. You may be too young to remember this, but in the olden days, all the negatives for film were developed in the dark room. And we don't want to be in the dark room. We want to be in the light room to be able to spread light and enthusiasm for what we do. And I want you to have faith, because you got to have faith in yourself to give faith to your patients. You got to feel more confident, active learning, believe in yourself, know you can do it. All remember the thinking skills and decision-making skills. It's not about cheap strategies. It's all about knowing your information and mastering pharmacology. And help link pharmacology by memory techniques. And remember, it's not the mountain that gets moved that makes the difference. It is the little steps taken one at a time. And we believe in you, and we know you can do it. And I am looking forward to working with you this afternoon during our question and answer. Please bring those questions. It doesn't have to be what we've looked at today. It could be any question you want to look at. I'm here for you. And you know, what I do want to share with you is that, and I'm not here about this, But Jennifer Robinson in the ICANN office is going to be sponsoring a Zoom discount for you today. And she'll help you in terms of, she can provide you packages, she can provide you information about, perhaps you'll tell her what you need, and she's going to give you individual discounts, because we do this for the convention to give you a major discount to help you, especially during this challenging time with COVID. And so she's going to be giving you this kind of a package, and then she's also going to be sharing with you a Mass Surge package as well. And what I do is on the right page, and we could talk about this later, I have the test taking strategy, and on the left page is the information to help you master it. But bottom line is, it's all about transforming pharmacology, making it fun and easy. Remember, with ICANN, you can be successful. We want to thank you for being here. We want to make sure that you do come. I'm looking forward to our question and answer series. And I want to end with a story during the question and answer series. We'll end with it at that point in time. But what I want you to recognize is the butterfly is all about transformation. And as you feel overwhelmed with pharmacology, remember, without change and without growth, we would not have butterflies. And so during this COVID season, I want you to have faith. I want you to have hope. I want you to believe and know we're going to move forward with all this. But first, it begins with you, because you're going to be the person, the professional, the human being that's going to be at the bedside for many patients that are going to be alone in the hospital. So yes, we're looking at pharmacology today, but we want to take a look at transforming information and make sure that we're providing spiritual care along the way. Thank you, each of you, for being here. I'm looking forward to talking with you later. Bring those questions. Take care, have fun, be safe, and God bless all of you. Thank you. Thank you so much, Trish, and welcome to all of you. I totally understand the concern in terms of doing this from a video standpoint, and I want you to get everything out of this because it's fun, and it is nice to be able to get your questions answered when you have them. I totally get that. That was a little frustrating on my part as well. So NSNA is always about making sure we have quality and making sure that all of us feel good about the information. So I want to begin to say, in terms of if you've got any specific questions, I would love to start with anyone that has anything that you need to clarify from the presentation, and or specific questions. If not, I've got some for you. So let's begin with any questions. And the other thing I want to I'm sorry, go ahead. Pardon me?
They do want to know if you will be able to make the slides available.
Absolutely. What we're going to do is, after the presentation, we always have those available. We will have those available for you today. At the end of this presentation, Jennifer Robinson will get those to Trish, and is that how you want to handle it? Tricia, have Jennifer send those to you and have them go directly to NSNA, or how do you want to do that?
Yeah, she can send them to me, and then I'll send them out. It'll take about 48 hours, ladies and gentlemen, to get the recording. So you'll get the recording and the PowerPoint at the same time.
Absolutely. Perfect. Thank you, Tricia. Yes, we will certainly get those to you without a doubt. Next question.
And we'll go back over on how to do the discount here in just a little while. So, but we can go ahead and put a poll up if you want to.
Absolutely. Now, one of the things before we do, absolutely. And one of the things before we do put the poll up, what I want to share with you is, first of all, I want each one of you to know how you're feeling is very real. I mean, pharmacology is an emotional topic to begin with because there's so much information. And that's the reason why I like doing it with you, even on Zoom. I mean, I've been doing these for months now, live presentations to help you gather and be able to understand it. And I like you to be able to ask questions after each session to see if there's each section, I should say, to make sure you're okay, so that you can see how we do apply it. So what we're going to do is, and I like your comment, Loretta. Has anyone ever told you that you look and sound like Catherine O'Hara? No, but You're so very welcome for your time. I'm here all about you guys and what it was the number for. We'll talk about that later because I'm here for you guys right now to make sure you're okay with general content. Let me see if there's anything else. Sorry if there's been asked, but will the slideshow be? Absolutely, sure will be. And can you please include the answers of each question in the PowerPoint? Please, absolutely, we certainly can do that. That is absolutely, because I do realize you're learning as we're going through, and when we're doing a presentation, we go a lot slower. I really appreciate this. Farm is daunting, and the speed of this was crazy, but so it was crazy because we were taping. You are so right. And once again, we're going to send this to you. It was crazy for me as well. And the other thing, you guys, is we're going to do Med-Surg live. Trish and I'd much rather do it live anyway. So we're going to do that live for you next week. You'll be able to, I will have the chat room monitored. We'll answer questions as we're going through here. It'll be a lot slower because you'll be there with us. How do you sift through all the information about drug and determine what's most important to create mnemonics? What a great question. I love the question. Well, first of all, what we do is I look at the NCLEX standards. And so all those NCLEX standards are really what drive this. And so with that in mind, I know what you have to know for nursing, and I know what you have to know for NCLEX. So all of the pictures, when you look on the right page of the book, whether it's nursing or maternity or med-surg or pharm, it is driven by what you're tested on. And I don't want you guys to think I'm just about a test, because I'm not. I'm about clinical practice. And so, but the good thing about the National Council, they're about clinical practice as well. So what I do is I take that, and then the left side is all about trade information, learning information. And then if it's testing, then the right is to help you organize and to remember the material. But what a great question. It's all about standards and concepts and how to think and what you're going to be held accountable for as well. Was the mnemonic memory for galantamine? That is correct. Yes, that is correct. The memory mnemonic was for galantamine, which is an anti-Alzheimer's medication. And once again, that was created from the standards. So those are not just what are nice to know. Those are what's necessary to know when you're looking at that particular mnemonic. I'm tired of getting grades that don't reflect my efforts. And if I am missing something, please, it's going that way. So I don't want to, it's moving forward. So I don't want to miss it. I understand the comment about, I am tired of getting grades that don't represent my knowledge. That's really how this all came about. That's exactly how all the Insanely Easy books came about, because students were saying, oh my gosh, I don't get it. And then what was happening is I was doing these in the classroom and the clinical, and they started saying their scores started going up. In fact, one of the deans called me in and she said, what are you doing in the clinical area and the classroom? And I didn't even know what I was doing, you guys. I was just teaching nursing. This is when I was a brand new educator. And what was happening is she said, do you mind if I come? I'm like, absolutely, come on. And what I was doing was I was using cognitive learning theory. And that is, I call it a stickiness factor to help you remember the material. And once again, you don't have to remember it in order. The mnemonics are not in order at all. They're just the major standards that you have to know. So when I did that, students could remember and scores started going up. And what happened was my students were all doing very well on the NCLEX, and the schools were going down, and they started tracking and saying, you're doing something that's helping the students do well. And that's when I said, well, come on, come to clinical, come to classroom. And that's when she said to me, you are helping them remember the material, and really the rest is history. And so it was you guys that really created this whole process, because I was just trying to help you remember and to take care of that anxiety, because I understand. And that's why I apologize that it did go fast, because I don't want you to be anxious. And that's why I want to repeat anything that we need to repeat for you, because it doesn't have to be that way. And of course, it's a lot different when we're together and when we're doing it live. But that's how it all got started from there. Could you repeat the mnemonic for each letter of memory? I will be more than happy to do that. Erica, would you find this for me in here? It's under galantamine. It's under galantamine, and it is under anti-Alzheimer's. And what we're looking at is, with this, we're going to be taking a look at, first of all, you have to think about it's for memory. It doesn't fix the memory, but it's to help with the memory. And so what it helps is gives them a significant increase in the activities of daily living is what we're looking at. And so that M is looking at the minimum of 4 weeks. So they're going to take it for 4 weeks before we change that. So minimum of 4 weeks to maintain prior to increasing the dose. The E stands for extended release in the morning. If it's an extended release in the morning, then they don't usually have to take it again. If they just take a typical medication, it's twice a day. So preferably they take that with food. So once again, minimum of 4 weeks before they change the amount. Second of all, E stands for extended release. Typically take that capsule in the morning and preferably with food. The M in memory, second M, stands for mild to moderate dementia of the Alzheimer's type. And once again, they're not going to ask you that, but it's nice for you to recognize that galantamine is for Alzheimer's. So if they say which would be a priority drug that you would know for Alzheimer's, that you would know this would be a drug, the drug for them to take. So mild to moderate dementia is that second M. So the first M is minimum 4 weeks. The E stands for extended release, preferably in the morning with food. The M, next M, is mild to moderate dementia of Alzheimer's. The O in memory stands for oral dose. Administer it twice daily. Once again, preferably morning and evening with meals. If it's extended release, they'd only take it 1 time a day. The R stands for reasoning, memory, language, ability to perform simple tasks. That is going to be the desired outcomes. So they're going to be able to do more of their activities of daily living. And they're going to be able to have the ability for reasoning and language to do that with. And the Y stands for, yes, the heart rate must be monitored because they can get into a low heart rate. So in review, memory stands for minimum of 4 weeks for galantamine before they change it. The E stands for extended release in the morning, preferably with food. The second M is mild to moderate dementia, is why we give it. The O stands for oral dose, administer it twice a daily, preferably in the morning and evening with food. Of course, if it's just extended release, it would just be in the morning. They'd have to say extended release. The R stands for reasoning, memory, language, and ability to perform simple tasks are the desired outcomes. And the Y is yes, the heart rate must be monitored due to developing of bradycardia. Did that answer your question that asked that? Is that okay? I don't want to miss anything. Trish, don't let me miss anything, please. Are there answers to questions that are obvious that we need to, so obvious that we can rule out? You know what we're going to do is we're going to compare and contrast. I'm going to do a strategy with you with some of these to demonstrate that, because I want you to be able to compare and contrast. In my experience, a med question usually mentions a body system or alludes to one. So then if needed, you can attempt to use patho to narrow down the related signs and symptoms and top the concern and concern with each system. Yes, you can organize. It doesn't always do that, but that's a very good question, Emily. And I appreciate you bringing that up, because yes, the patho, if you know the patho, your pharmacology, you can really pull it through. And you'll notice that every one of my mnemonics, every one of my pictures or my songs is going to bring in that kind of information. But yes, unfortunately, sometimes they'll just say which is a party drug and they don't put anything in there in terms of to give it to you. But yes, if you can know the system and pull that patho, you're going to be doing it great. And I will explain that to you, also on the left side where we always have the mode of action, I always pull that through, and I try to do that with the mnemonic or the song. So that's correct. I know this is not about farm. Wait a minute. Let me pull this down. I know it's not about farm, but what's the best way I can accomplish nursing lectures courses so that I can be a competent nursing student? What a great question. What you're going to do is next week, I'm going to be talking about a model to organize all of your information, and it's going to be called safety. And that is about clinical decision making. And so I'm going to show you how to use that you can do that while you're in school. So you're looking at system-specific assessment, system-specific physiology. I'll do this again next week in an organized fashion. System-specific labs, And then you'll take a look at analyzing that. And then we'll look at first, how do you organize first? I'm going to show you how to do that too, because all the med surg is organized that way in my book, so that you can make your whole standards organized that way. And then we'll look at first, perhaps the first drug, which is what we're doing today. And then the E would be evaluation, the T will be trend, and the Y will be management. We'll do more of that, but it was still a good question. And what I'm asking you to do with pharmacology is I'm giving you a structure for standards on that right page with each one of them. Scarlett, that was a good comment, and it's okay because pharmacology is part of nursing, but I hope that answers. We'll give you a structure to organize that with med surg and with pharmacology. On the right page, I've got the standards, which is what I went through today in a very, in a very systematic fashion, but I realized it was quick. Dawn, will
Loretta,
you send the email? Yes. Go
Sorry,
ahead,
you missed a couple. There was one that's up a little further that says, so the 3 mice are for all mycins.
Good comment. And you know what? There's a lot coming in. So thank you, Trish. Just keep me on it. Thank you for being a great moderator. There's a good question on the table that is saying, are the mycins, the aminoglycosides, all for mycins? No, they're not. If we were doing a full day, and you'll see that as you look at these questions or these scenarios in a book. Here's the thing, guys. Erythromycin, I'm going to go slowly so you guys can take notes. Erythromycin is not part of this. Erythromycin is a macrolide antibiotic. In fact, in my book, I use Zeb the exterminator, and I have a little song. She'll be coming around the mountain when she comes. And Zeb stands for these macrolides, and they are Zithromax or Z-Pak. You probably are familiar with those. E stands for erythromycin, and B stands for Biaxin. And those are different. Those are macrolides. And so, and once again, all of those come into a little song called She'll Be Coming Around the Mountain. In other words, they get into complications with anticoagulants and interactions. They can get to liver interactions. They can even get into bleeding if they're taking other drugs with those. But once again, Zithromax, erythromycin, which is a question, erythromycin and Biaxin are macrolides. Then you've got, in terms of, you've got your chemotherapy antibiotics such as adriamycin, and those, I call them the SINs in the pharmacology book. Those are all of your anti-tumor, in other words, anti-neoplastic antibiotics. The biggest one being your adriamycin. That's a mycin as well. Okay. So right now you got erythromycin, which is a macrolide antibiotic. Very good question. You've also got now your adriamycin, which is your anti-neoplastic antibiotic. And then we pulled out vancomycin because vancomycin is going to be used more for your pneumocystis carinii. In other words, your HIV opportunistic organisms. And we did with vancomycin, that's where we went ahead and we sang the Rudolph the Redneck Ranger, because with vancomycin, they can get into problems with the redneck syndrome if it goes in too quickly.
All right. Andrew asks, what drugs are included in the book?
What drugs are included in the book? What a very good question. The drugs, and then one thing I wanted to say is, remember, streptomycin, gentamicin, neomycin, all of those are the rest of those then become your aminoglycosides. In your book, I'm going to do a quick overview very quickly. We have cardiovascular, which includes heart failure agents, adrenergic agents, anti-anginal agents, your antidysrhythmic and your antihypertensive drugs. And what I've done is I've organized all of these specifics to give you a quick way to find them.
We're getting feedback. Could you please make sure your microphones are muted? Go ahead, Loretta.
Okay, thank you. Thank you, guys. Thank you, Trish. The agent for hypertensive crisis, anti-lipemic agents, remember, I'm going to go very quickly here. Diuretic agents, all of them, all of your anticoagulant agents. We have all, and that includes anticoagulant agents, direct thrombin inhibitor agents, direct factor XA agents, and antiplatelet agents, and your thrombolytic agents. And I have all of your respiratory agents organized around agents for airflow disorders versus upper respiratory disorders. Then all of your anti-infective agents, which includes the bacterial cell wall, which gets your penicillins, that gets your cephalosporins, then your vancomycin, and then agents for protein synthesis, which are your tetracycline macrolides. It gives you an idea. I'm not going to go through each, but you'll get a feel. Agents for urinary tract infections, anti-TB agents, antifungal, antiprotozoa, and antiviral. Then I have all of your anti-HIV agents. Then I have your urinary agents, and then I have all of your anti-neoplastic agents. But here's the deal. With those anti-neoplastic agents, if you know the concept page, it covers all of them. Same thing with your anticoagulants. Then I've got your growth factors, your anti-inflammatory agents, anti-gout, rheumatoid, GI. GI is around anti-ulcer, gastrointestinal disorder, irritable bowel disorder. All of your endocrine agents, which include your adrenal hormonal agent, which is like your corticosteroids, your thyroid agents, which is your Synthroid. Then you've got your anti-thyroid, pituitary, and then all of your anti-diabetic agents. Then we got central nervous system agents. They're all divided the same way. Anti-migraine, anti-Parkinson, anti-convulsants. Then all of your psych drugs, and those are fun because there's easy ways and charts with that. That's your anti-anxiety, antidepressants, anti-manic, antipsychotic. Then your substance abuse, which includes your agents to support withdrawal from alcohol, from opioids, from nicotine. Your anti-Alzheimer's agents, I give you a taste of that. Your reproductive agents for labor and delivery, for reproductive, for bone, men's health, then your vitamins, then all of your immunizations, your complementary. I know that was quick, but anyway, it's an overview. And here's the deal, you guys. When I first started this 5 editions ago, I did it because students were saying, would you please do this? I'd already done a nursing aid and St. Easy. And they go, would you please do a pharmacology? And I'm thinking, oh my goodness. But here's the key. The key is that the right page makes it so understandable. And when the left page is more of the general facts. And then the right is your strategies for testing. What I did today, you guys, is I was giving you a way to make it sticky so you could remember it for testing. But the left page is all, I'm a nurse practitioner. I did trauma. I'm very anal. So I'm very into the details. So the left page is the information you would learn while you're in school or to help you with clinical. But remember, the right is how to organize it from a testing standpoint. I hope that answers the question. Trish, another question?
Yep. If you see a drug that you do not recognize, what is the best way to figure out what it does from the question / the answer?
What a great one. Trish, let's pull up the first question. I'm thinking you got one of those in your first poll question so I can demonstrate this for them. It's a great question. There's a lot of different ways to do this question.
Hold on. 1 second.
Okay, you guys, the thing is, there's a lot of different ways. And so what I want to show you, a lot of it's compare and contrast while she's doing it. You look at the stem and then you compare and contrast your options. And I'm hoping that we've got this first one that may very well demonstrate that once she pulls this up here.
It's giving me an error. It says that I'm logged in multiple locations, but I'm not. So
okay, you know what?
You want me to read it? You want me to read it to you?
Why don't you read it to them? Why don't you read it to them?
Okay, give me just 1 second to pull it up. 1 second.
And you guys, here's the key is, because what I want you to do is there's a lot of different, not a lot, but in my program, I show you that. I do 1 whole hour on actually strategies. And what she's going to do is, the question I want you guys to recognize is, which of these are we going to question with the client getting erythromycin? Now, erythromycin is a macrolide antibiotic. And if you can't do it, don't worry about it. It's fine. So the key is, it is about erythromycin. It says, which of these are we going to question? Now, here's the key, you guys. Which of these would we not want to give with erythromycin? And one of those is like cisaproside, in other words, propulsid. So you might want to jot that down at home. Write down propulsid. Another option is going to be lisinopril. Another option is lisinopril. Another one, I'm doing this off the top of my head. Another one is lisinopril, propranolol. Let's just put propranolol out there. And then another one is captopril. Okay. So you guys, now some of you are not some of you are not auditory. So let me say this again. We have a question about erythromycin, and we're saying, which of these are we going to question? And we've got a couple prils. We have a law, and we have propulsid or cisapride. Now, what you want to do with that excellent question you guys just asked, you want to compare and contrast. For one thing, you know erythromycin is a macrolide antibiotic. You may not know that, but I'm just telling you. And it's a mycin, it's erythromycin. And erythromycin has many, many, many interactions. That's the reason I pulled that out, because it depends on P450, which I would do all this in actually full day course for your school. The key is you may not know all that, but what you do know is you know what you have in front of you. You want to compare and contrast those 4 drugs I gave you. You have a couple of prills, you have a law, and you have an odd drug out there. You have no idea what the answer is, perhaps. But what you know is you have 2 prills. Did I give you, I hope I gave him 2 prills is what I'm hoping I did this right. So
I did put that question in the chat.
Okay, in the chat. Okay,
Yep.
in the chat. Let me see if I can find it.
It says,
oh, here we go. Perfect. You guys, it's in here. Thank you. Thank you. Okay, so on review of a client's history, what current medication would be contraindicated for this? Or we could say, would we question it? That's another standard. And the key is, we don't know, but we know that we got 2 prills, we have 1 law. What do you guys know about that? You know those 3 are antihypertensive drugs. So if you've got 2 right now, 2 and 3, they're the same. So get rid of them because they end in prill. Those are ACE inhibitors. Then you've got 1 and 4. 4 is a beta blocker because it ends in law. So you've got 2, 3, and 4 are antihypertensive drugs that work on the heart, the system, like the question you guys asked. And then you have odd man out. Now, by the way, the answer is number 1. And by the way, it's been taken off the market. And I did that intentionally because it was taken off the market because clients were dying from lethal cardiac dysrhythmias because erythromycin goes to the first pass of the liver. You don't need to know that right now. What you need to know is nothing but a decision-making strategy like you were asking me. So you got 3 heart drugs, the odd man out is your answer. But the rationale for it, I always like you to learn, is many drugs that go through the first pass of the liver. I'll give you some examples right now. Erythromycin is one. Rifampin for anti-TB drugs is another one. Azoles, any of those antifungal that end in azole is one. Birth control pills are one. And in fact, I've got one page that has all of your hepatotoxic drugs for you, actually in one of your resources. But my point is that you did not have to know this. You know that erythromycin is a macrolide antibiotic now, but what you do know at this point is that you have 3 drugs that are cardiac and the other one's odd man out. Does that answer your question, guys? Does that help the person ask the question?
The other thing that they would like to know is, while we're going on this, could you possibly show how the book is laid out, like put the book up to the screen so they can see what it looks like?
Okay, yes, absolutely, I can do that. And I think this is what they're asking me to do. Is this what you're asking me to do, guys? On one page, you will, yeah, okay, good, because I'm learning this technology. I got my technology expert with me, so whatever you need, we can do. The left page is the analytical. I use cognitive learning theory with my books. So the left side is all the analytical information, and the right side is a way to remember the material. In fact, you know what, guys? Hold on just a minute. Let me pull up ACE inhibitors for you because we just talked about it. And it's a different drug that we didn't do in there. So let me pull this one up for you so you can see, you can get a feel here. Okay, so on the left page, and all the left pages will have the same. And what it will be, guys, it will be examples of actions, indications, warnings, undesirable effects, other specific information. And you guys, I'm feeling a little badly because I am not here about the book. I'm here to help answer questions. So I just wanted to be aware that I'm just trying to help you be successful. The other page is the image. And what I've done is, with your ACE inhibitors, you'll see Stroll is the physiology, like what does ACE inhibitors do? It blocks conversion of angiotensin 1 to 2. So what it does is it's going to help decrease the systemic and vascular resistance. So I'm giving you the physiology over here. The ACE is the nursing or the undesirable effects you want to think about. A stands for angioedema, because you want to be concerned with the angioedema because they can die from airway issue. The C is a cough, because with ACE inhibitors, they can have a cough, and sometimes you have to prioritize care. So remember, they're not going to die from a dry cough, but it's annoying, and they'll quit taking their medications. So we might think about, what we might need to think about is notifying the provider on that. Contraindicate if they have any kind of renal complications. In other words, monitor the blood and creatinine. And you start to see the standards over and over with these medications. And then the E is to evaluate for hypotension and for hyperkalemia, because what do ACE inhibitors do? They block conversion of angiotensin 1 to angiotensin 2. So what's going to happen is that blocks the retention of sodium, but when that does that, potassium can go up. If you understand, all these mnemonics are about understanding and not memorizing a bunch of words. So if you think about ACE, you got everything you need to know with ACE inhibitors. You got your angioedema, you have your cough, you have your contraindicated with renal complications as evidenced by the BUN and creatinine, and then you have evaluate for low blood pressure, and then evaluate, for example, for hyperkalemia. So your left page information, the right is your strategy, and it goes, and then what I do is I've got concept pages to help you with that as well. Did that answer it, Trish, and those of you that asked the question? Will you email us how we can get the book? And we can talk about that as well. Absolutely. Yes, we will do that. Because depressed ST waves represent myocardial, prills are ACE inhibitors. Good question. Now, remember, you guys, keep in mind, depressed ST segments are going to reflect, I always say, 1 foot in the grave, and within MI, it's high. So in other words, you're going to have some angina when you have a depressed ST segment. But remember, what you have with the MI, you're going to have a high ST segment. When you think about your prills, you're going to be concerned with elevated T waves. There's a difference between a T wave that's elevated. That's part of the normal sinus rhythm, and it could be a dysrhythmia. Remember, when you're looking at ST, you're thinking about ST would be depressed, would be angina, like you said, or elevated would be an MI, that would be high. But remember, with your ACE inhibitors, we're concerned with elevated T wave, because the T wave indicates the potassium level.
So the question,
does that answer that, Elizabeth? What a great point. Pardon me?
I had put out number 2, which was for your poll, which was which of these findings would be most important to report for the provider for a client who is taking benzapril.
Perfect. Thank you so much for doing that. So the first thing, you guys, we want to look at benazepril. Now remember, it's a prill, so it's going to be applicable to all of them. I want you guys to study in the families and categories, and then if there's something specific to one drug of those drugs, I will put that on the right mnemonic or on the right side of the page. Also, at the bottom of your left page, I will give you all the drugs and play off what they end in. So these are prills. So with all of them, we're going to be concerned with. And the concern is, now that we've looked at this, the answer is the BUN here is going to be 10 to 20. So that's not going to be something, which of these would be most important? That we don't have to report a normal BUN, because that's 10 to 20. So that's normal. The creatinine level, that creatinine level is normal. We don't need to report that. The depressed ST wave is about angina. We're not going to report that. We're concerned with hyperkalemia, the high potassium. So the answer is number 4, because of the spike T wave. That I see where that question was coming into play, because the thing is, what we're looking at, it becomes about the drug. I like that question that you guys were asking me. If I would have said a concern with angina, then we would go with that depressed ST wave. But because it's all about that benazepril, when they add the drug, the question usually becomes about the drug. And if we were doing a one-day course, we would go through all of those systems and look at the difference between if it's about the concept or if it's about the drug. But the point is, right now, in just a minute or less, if they add the drug in there, it's probably going to be about the drug. So it's going to be about a spike T wave. So the answer is number 4. Does that make sense to everybody? Any questions about that? Any questions? And that kind of went along with ACE, with your ACE inhibitor from there, looking at angioedema, the cough, the issue with the contraindicated with renal compromise, and then the issue with the evaluate for the blood pressure bottoming out or evaluation for hyperkalemia.
Joanne asked, why did you say that spike T waves was the wrong answer for lisinopril?
Very good. Thank you. And Joanne asked the question?
Yes.
Thank you, Joanne. What a great question. Thank you so much for clarifying that for us. The reason why I said that is because which of these findings would be most important to report to a provider who's taken benazepril? The thing you want to remember is, with a prill, they can get into problems with hyperkalemia because of how it works. It works by blocking the conversion of angiotensin 1 to angiotensin 2. So that's a potent constrictor. So they have to have renal function into place. What we're concerned with is, when you do that, they blocks that conversion. It blocks that. Think about aldosterone, and that's really actually in that stroll. It's actually is part on that right page. Stroll is the physiology. It's actually out there for you. But what it does is, while it decreases that aldosterone, what happens is they decrease that absorption of sodium. So what happens? They hold on to potassium. So a real concern with your prills, they get into hyperkalemia. That's a complication. Now, the thing is, I understand what you're saying. You're going, well, it's a depressed ST. We're worried about that. Keep in mind, that's not what they're asking. If they said, let's make that an answer, because it's a great question, you guys. If they said a client comes in and they have a new order for an ACE inhibitor, but while they're experiencing chest pain, which of these changes on the ECG monitor or which of these assessments on the monitor would be highest priority to report for a client who's presenting with this complication? At that time, we haven't started the ACE inhibitors. It's not even about the ACE inhibitors. It's a new order. We're not even going down that path. Right now, we're looking at the concern with angina. And then we got an assessment here. We need to be careful with that depressed ST segment. That indicates a problem. It confirms that they have angina in place. But that is not it's because that's not what the question is asking. The question is asking that's taking the benazepril. So once they're taking the drug, it becomes about the pharmaceutical agent, which is the prill, which means we've got the concern with the hyperkalemia. And we go back to ACE, that angioedema, they'll cough. Even if cough was on here, it still wouldn't be an answer because it's annoying. It's just annoying. The issue is with a spike T wave, they can go into cardiac dysrhythmia, go into ventricular, and get into major problems. So that's the rationale. Does that make sense? It's a really good question you asked. Does that make sense?
So if a patient starts to have a dry cough, do we stop the med?
That's a very good question. Now, once again, remember what I'm doing. I've got my hats on because it depends on what you're comparing and contrasting to. That is correct. If indeed, let's just do this in isolation because they're not going to die from it. If they say another question says the client presents with a dry cough, what you want to do is you want to notify the healthcare provider, or that should be part of the teaching. Teach the client to notify the healthcare provider for a change in agent, exactly, from the dry cough, because they're going to quit taking it because it's annoying. It's from that renin response, and they just get tired of it. They're not going to die from it, but they could die from hypertension because they're going to quit taking the drug from there. So absolutely. But if they say which of these are priority to report, and one is a dry cough versus one is angioedema, the priority is going to be angioedema because that swelling, I can obstruct my airway. Or if they say a dry cough or a spike T wave, you're going to go with a spike T wave. Now, those of you guys that are starting off in nursing, and I don't know where all of you are at, you need to recognize I'm taking you to the level of high-level decision-making on prioritization. We have to master drugs first before we get there. So yes, you need to know about a dry cough, but I want you to keep in mind, I don't want you to memorize and go, it's always going to be a dry cough. I want you to recognize it depends on what the question is asking you, because you're going to have to compare and contrast those. Does that make sense? So bottom line is, teach them about the dry cough. The answer is report that to the healthcare provider and they'll probably change it. But if they have a life-threatening dysrhythmia of a spike T wave, the priority would be the spike T wave over that cough at that point in time. That just becomes a higher level question. Trish, does that answer that for the group?
I think so. Joanne just said,
question, guys. Good question.
Joanne just said for some reason she had noted that in the lecture you mentioned spike T waves was wrong for hyperkalemia, and if it was flattened, then we'd be concerned. But yes, she now sees that hyperkalemia.
Oh, you know what? You know what Joanne's talking about? Joanne, thank you so much. What a great point. That was with amphotericin. Thank you, Tricia. That was with amphotericin. With amphotericin, they get into a low potassium, which would be a flattened T wave. That was with so watch for low K levels and toxic signs as well. With that drug, they do get, it's like Lasix. They get to low potassium. They're not going to present with spike T waves in that situation. ACE inhibitors work differently. That's why if you know how they work, it's going to help so much. Because with Lasix and loop diuretics, they lose potassium. They're going to get into a low or flattened T wave. In the lecture, Joanne is exactly correct. With amphotericin, I said they're going to get into a low or inverted T wave because it can lead to ditch toxicity, or in other words, with amphotericin, they get into low potassium. So drugs that get into a low potassium are not going to present with a spike T wave. They'll present with a flattened or inverted T wave. Does that clarify? What a great clarification, Tricia. Does that make sense, guys? Come to the chat room and let us know. Am I making sense, everybody?
Yes, they're saying yes. The
Great.
big thing
Here's
that they
a great
keep going
question.
back to is, do you guys have a website that they can purchase the books, or do they need to call Jennifer, or what's the best? I keep asking about the books and getting
Okay.
we want to make sure.
Okay. You guys, okay, let me give you the telephone number because that's right, they weren't able to copy that down. Okay, let me give you two things. The telephone number is the following: 770-495-2488. Once again, 770-495-2488. Erica, which website is she going to? Are they going to just ICANN Publishing? So if you want to go to the website, just go to icanpublishing.com and icanpublishing.com. And she's got coupons in there, correct, Erica? Coupons for discounts. What I want to share with you is, first of all, I appreciate you asking. I want you to understand my agenda is to help you be successful. I want you to keep in mind too that you can, we've got packages, but we want to get you what you need. And if you only need one book, then you just need one book. So if you want to call her and tell her what the needs are, she can help you with that process. So once again, that's why I want you to have both the web page, and we're going to also send the information. Ask Jennifer to put that on the chat room for me, Erica. To go, can Jennifer do this, or can you do that for them? Oh, she's already got it on here. Wonderful, we're on here. It's in the chat box. Perfect, Jennifer, we're in there. So she can help you with that, and because we only want you to get what you need, or if you don't need anything, that's okay too. But it will definitely help you so very, very much. And we're going to do the same thing with the convention process. We'll do the same thing for you with the Med Surge. And the good thing is we're going to do this live again with Pharmacology. And you guys, if you want to, I'll tell you what, to give you a double whammy for this, if you want to put in the chat room, and I can look at the chat room or ask Tricia, if you want to tell me what kind of drugs you want me to go through, I'll be happy to do another one for you, because you're going to get this in a taping series. We're going to send it to you, but I'll be happy to do another group of drugs for you. I love that because I do these all the time, and I also do these as programs for you. So, you know, you guys can tell us which kind of drugs you want me to look at, and I'll be more than happy to do that, incorporate that in our next Pharmacology live review from there too.
There has been several people that want to know, besides doing pharmacology, do you have a session that could help them memorize or learn lab values and electrolytes, or suggestions on how to do that?
Absolutely. We have what we call, thank you for the question and the comment on the floor, and make sure I got this right, Tricia. What the group is asking is, do we have a session for labs and for fluid and electrolytes to help memorize, correct?
Yes.
Okay, yes, we do. We have what we call a STAR program, and that STAR program is to help you. We take fluid electrolytes from beginning to end. You will absolutely love it. And labs are a part of that. And we organize them. And let me just give you a little sneak preview here. For example, let's just look at fluid. Let's just look at dehydration for just a moment. You know, when a client's dehydrated, think about what happens to the weight. The weight goes down. What happens to skin turgor? They're dry, it goes down. What happens to the blood pressure? It goes down. Everything goes down except the heart rate. And the heart rate goes up, but it goes down, it goes up, excuse me, heart rate goes up because there's a decrease in volume. So I had to be creative on that one. But everything is down with this assessments except heart rate goes up. Now, when that happens, what happens to your labs? Everything goes up because it's concentrated. My point is hematocrit goes up, BUN goes up, serum osmolality goes up. In other words, you will learn, like, it will be just that quick. And then you can apply it across the curriculum. So we call it STAR because it's strategies for thinking, you know, memorizing, application, and review. So we take that, and if you come next week, we're going to be looking at SIDH. We pull that through with your fluid volume, and you'll see how that works. But yes, we'll do all your labs that you need to know, which really you'll be fine, because it's all about what to do with them. I don't want you, and it's going to be how to memorize them, but you have to understand what we're all about. It's how to apply it. It's about decision making. You know, my job is help you. Less is best, but I want to link it so you can think it. And there's all kinds of images out there on the market, but they're not focused on NCLEX, or I don't want to say NCLEX, but standards. It's all about standards. So yes, we do. It's fun, and and Jennifer can help you with that as well. At that number, we can go into more detail with that as well.
All
Does
right.
that answer the question? Any other?
I think we've got a lot of lists of stuff to give you on some other drugs, OB drugs, common adult, antipsychotics. I will get you this chat so that you have it.
Okay, that'd be great, because I was going to say I'm not running because I'm focusing on you guys. So make sure I get that, and we will tailor this for this group without a doubt.
So, and then this next question is really for me. So yes, we pre-recorded the video this morning. What I will do, since there was so much chatter during the video, is I'll take that pre-recorded video and I'll splice it into this question and answer. That way your guys have a clean video. There are a few delays that come through with those, but I will get you guys that information. That will take me a little bit longer, so expect the video and the slides for this first presentation by Tuesday morning, just because it will take a little while for it to process. Again, I thank everyone for coming, and I know we've got another question. They said that they don't see any coupons or discounts on iCanPublishing.com.
I just saw that Erica's reaching out. Jennifer should be on this. There should be, I don't know if she's got the discount packages, but let's call her, and Erica's reaching out to her right this moment to see what's going on with the coupon. There should be, it might be it's already built in for the conference, but we're checking with that right now. Because yes, you are getting a conference discount for this, without a doubt. And if you can hold on 1 second, she's going to come back to us and get that to you. And I just want to, while we're doing this, I just want to say thank you guys for your patience. This is part of, we're all in this together. And I think the one thing you're learning as nursing students is to be upfront, so that, and I love your honesty. Excuse me for a minute. What's she saying?
While she's doing that,
Put the code in NCLEX. Okay. Put the code. I bet you I put that out of my brain, Trish, is what I did. Put the code in NCLEX.
NCLEX. Okay, I'm putting this in the chat so you guys have it, but it's just code NCLEX.
And if you aren't getting that, go ahead and give her a call. Yeah, give her a call from that standpoint for her to take care of. But what I want to say to all of you is that it is all about flexibility. And I'll be honest with you, in terms of, we're partners in this process. Trish and I are partners with you. And so we are very indebted to you for sharing with us your concerns. And, I'm very happy, like I said, to do the next few live. I love being live. I'd rather be in the same room and stopping with each of your questions. But with live, we will get the questions answered as we go as well, because I will also have a team that will help monitor those, as well as Trish will be with us as well, to make sure your questions all get answered from there. I also want to remind you, we're all about transformation. And there was a story about a little butterfly that was on the beach, and a little boy, 6-year-old boy, found it, and he was in a cocoon. He was like, we're trying to get out of there. He was trying so hard to get out. And before his dad could say anything, his little boy goes, my grandma's got scissors. So he runs to the picnic basket, cuts the cocoon, and this butterfly was beautiful colors. But unfortunately, the butterfly wasn't quite ready to go. Wasn't quite ready, pretty close, but not quite ready to fly. And so that's what I want to say to all of you, is that, you're all going to be close to ready, and we can't do the work for you. We got to work to the end. But, I understand your undertaking, and I want you to understand that we're in this with you, and we want you to succeed. It's all about your success, and we need you out there, every single one of you. We need you to be nurses. And so I want you to keep in mind that while we can't do the work for you, we certainly can provide you with a lot of support. A lot of support with maternal newborn, a lot of support with med surg, with nursing, with pharmacology, and we can do that for you. And the other thing is, I want you to always know, you've got our number now. Keep that number. When you get these, our relationship is just starting. You call me any point in time, and call Jennifer. Jennifer, she will stay on my bottom until I get a hold of you. Trust me. She always knows where I'm at. Between she and Erica, they will make sure. Our rule is 24 hours. But we're not traveling, so we should be good to be able to get right back with you, unless we're doing series, because we do programs when we're not doing this. So I just want you to keep in mind that our resources can help you. And if you have any challenges when you're doing them, just call me and let me answer questions. The other thing is, the reason there's always changes going on is people like to add certain things. So if you want something added, or you're having trouble with something, call me and we'll work through that together. So any other questions before we do get started? And I do see I'm interested in that STAR program for yours. And so what I would like to do is, please go ahead. Trisha's going to forward these to us. Jennifer will be following up with you, but please do get in touch with her today so that you can get those discounts. And in the meantime, before we do wrap up, I just want to say, are there any other questions? Any other questions?
There is one more. Do you have anything on mental health?
Now, okay, now let me ask you, mental health. What I want to share with you is, we've got if you're trying to be a mental health expert, a nurse practitioner, no. If you are looking at questions, I have a chapter in the 101 book on questions, all the questions for mental health and the NCLEX standards. In the Nursing Made Easy book, we've got the standards that we bring alive. The Nursing Made Easy book is very similar to the Pharmacology book. It's just that it's nursing standards. So that's the right and left. So we've got your information like on post-traumatic stress, schizophrenia, those kinds of things. So yes, in that one we do have the issue with mental health. We do have some issues with depression and anxiety in the maternal newborn book, but it's strictly for the mother standpoint. So really the big thing, and then Pharmacology's got all of your antidepressants, or excuse me, all of your psychiatric medications are in the Pharm. So Pharmacology, medications, 101 questions, and then we've got a psych area that reflect the standards. Once again, the standards are to bring it alive. It's not to say that it's a textbook. I want you to be aware of that too. It is the standards, and the right page is the way to remember it. The left page is the general information. Does that answer the question? Do you have a digital format for the books as well? That is something really good question, Stacy. Thank you for asking. We're working on that as we're talking. So we're going to be providing you with both. We're not there yet, but it's around the corner, literally around the corner. We will. The reason we've not done it at this point in time is because students, we do these with workshops and they like to have the copy, but we're gonna be able to have options for you. Probably the next time we do in SNA, we'll have it ready to go. At this point, no, but you can always keep in contact with Jennifer and let Jennifer know that you want her to contact you when it's ready. She's coordinating that. She and Erica Manning are coordinating that, so they can let you know that information. And you can get a hold of Erica through the same number with Jennifer too. Good question, and thank you for asking. Trisha, are you automatically emailing us with, oh, that's a Trisha question.
Yeah, there's one more for you, and I'll do that. Do you have any books on geriatrics?
Geriatrics throughout the Med-Surg book, yes. The Med-Surg book has got geriatrics with cardiac, geriatrics with neuro, so we have a page with the geriatrics, a part of it, because I'm actually a geriatric nurse practitioner, and honestly, you guys, what I experienced is, it's nice to learn it as you go through there. You know, so, and then I've got, in terms of some of the medications, of course, in the Pharmacology book, and then in the Nursing Made Easy book. In the Nursing Made Easy book, it's just concepts. So I don't think I've got anything that's just strictly geriatrics there, because geriatrics, they experience each of the similar complications. So it's the Med-Surg where I have that geriatric piece throughout there. But it's not actually one chapter, it's incorporated with the concept, but it's got a geriatric title on it, and it's got an old lady. My mom didn't like the old lady. I got to change the image for her, but she said it was too old. But anyway, bottom line is it depicts the information. I do have development in the Nursing Made Easy book. I've got all of development, and I got fan caves, which are all the problems with geriatric. I got all the skin with geriatrics in the Nursing Made Easy book as well. So.
All right, well, I think that is it. So first of all, I want to tell everybody thank you. I have to echo what Loretta says. There are sometimes the technical glitches that happen. I think it just sometimes happens. Plus, you know, also getting feedback from you guys that you don't want this live, that you need this interaction. So we'll work on that. We do have some recorded sessions coming up with NSNA in general that are more for that, but for these sessions, we will keep that in mind. We will get you guys the slides, and the video. That will probably begin Tuesday morning because it'll take me a little bit to process the video. Also, I will work with Loretta to get you guys a date for another live session, which we'll try to do within the next 2 weeks. Again, if you will pass that on to your colleagues that have got off the call, that there will be one, but everyone will get an email invite for that as well.
And oh, I'm sorry. Go ahead. Excuse me.
No, that's okay. And then, of course, MedSurge is next Friday, same time, same place, but this time it will be live. So just make sure that if you haven't signed up, to think about signing up for that. And again, my apologies that the technology issues happened earlier. We really appreciate, this is a new thing for everyone. And sometimes the internet, you will hear in the recording that you do get, you'll have a little bit of pauses here and there. It's just what the internet does these days, but that's what we'll continue to work on. So Loretta, a big thank you to you, your family, and your staff there. It's, I don't know. I'm now singing those songs. I've been a nurse now since 2003 or 2002. And, it was like, oh, I remember those. So anyway, again, thank you. And thank you for everybody that stayed on.
Well, you're so welcome. And two things, if I might add, if you don't mind.
Absolutely.
Just remember, in terms of, if you guys have anything from MedSurge, feel free to put that in the chat room too. We can tailor that for you as well. And the other thing I just want to say to you is, remember, everything in life is what you make it. It's not what is in life that counts. It's simply how you take it. Remember, it's not what happens to us. It's how we overcome those. And the most successful people are the individuals that have had to overcome. And every one of you can do this. And we're going to do this together. Out of this, you're going to get another pharmacology review, and I will tailor this. And so thank you for all of you. Thank you for Trish, and have a great weekend, and we will get information to you, and God bless all of you. Thank you for being here.
And just so you know, if you're not able to get on MedSurge or the next pharmacy, we will record them. They will be done live, but we will record them. So, all right. Again, everyone have a wonderful afternoon. Enjoy the rest of your Friday, and we'll see you guys next week. Thank you, Loretta.
Thank you. You're so
Bye,
welcome.
everybody.
My pleasure. Thank you so much.
Yes, recordings will be sent out next week. Thank you.
Yes, I come.